Everyone to the 22nd Northwest Patient Safety Conference. This session is Implementing Diagnostic Excellence Across Systems. All presentations are being recorded. Presentations, slides, and speaker contact information will be available on the conference website after the conference. Educational credit information will be sent to you after the conference as well. Please submit questions during this session using the chat function here in Zoom. Our speaker will field questions after her presentation. Well, it's my pleasure to introduce Dr. Sangeeta Ahluwalia, who is a senior health policy researcher and the associate director of RAND Health. She leads research funded by AHRQ, NIH, Patient-Centered Outcomes Research Institute, and CMS in the areas of diagnostic safety, palliative care delivery, and patient-clinician communication. Dr. Ahluwalia received her PhD from UC Berkeley and a Master of Public Health from UCLA. Welcome, Dr. Ahluwalia.
Thanks, Jonathan. Really appreciate the warm introduction, and thank you to everybody who has joined. I really appreciate seeing the audience and the interest. So, as Jonathan mentioned, my name is Sangeeta, and I am co-leading this project that is funded by the Agency of Healthcare Research and Quality, along with my PI, Dr. Courtney Gedengal, who could not make it today, but she is a pediatric infectious disease physician at Boston Children's. And today what I'm going to do is I'm going to talk a little bit about 3 diagnostic safety resources that AHRQ has helped to develop and is now funding widespread implementation of in practice. I'm going to actually focus on one of the 3 tools, but I will give you an overview of both so you can just get a sense of what's available to you and your teams who might be interested in improving diagnostic safety. So, as is probably no surprise to this esteemed audience, diagnostic safety is critically important. We know that diagnostic safety events contribute to preventable harm in about 1 out of 20 outpatient visits annually and up to 250,000 inpatient stays. They are also the most common root cause for medical liability claims. Improvement of diagnostic safety can be challenging, and we know that healthcare organizations and practicing clinicians need really practical, flexible resources that can be implemented into existing workflows to support diagnostic safety improvement efforts. You all probably also know that AHRQ has been operating in the space of patient safety and increasingly in diagnostic safety for a while and is very committed to improving diagnostic safety. As I mentioned, they have developed a range of different diagnostic safety resources to support improvements in this area. The 3 that I'm going to talk about today were created by Baylor College of Medicine and MedStar Health, as well as other key clinical partners, and they have been tested with clinicians at multiple institutions. So right now, having developed these resources, AHRQ has contracted with us at RAND to lead this project, the IDEAS project, to essentially recruit healthcare organizations around the country to implement these 3 diagnostic safety resources so that we can evaluate their use in practice, identify improvements to the tools, and identify improvements to how these tools are incorporated into clinical practice so it becomes easier and easier for clinicians and healthcare systems to use these tools. So the 3 tools that I'm about to talk about are really aimed at improving diagnostic safety across different settings and different users. So for example, the toolkit for engaging patients to improve diagnostic safety is really focused on the patient-clinician interaction and communication during that interaction. And it is ideally implemented in office-based settings. Measure DX, on the other hand, which can be implemented really in any healthcare setting, is much more focused on quality improvement and using existing data on healthcare quality to identify opportunities to improve diagnostic safety, to identify and report diagnostic error or harm. So it is most frequently used by QI teams or patient safety teams at the hospital or organization level. And then Calibrate DX, which is what I'm going to spend a little bit more time talking about today, is aimed at improving individual clinicians' diagnostic performance, really focused on calibrating their thinking around diagnostic performance. And it can be used in any healthcare setting by clinicians whose scope of practice includes diagnosis. So I want to just pop up a quick poll to get a sense of this audience and whether you are aware of any of these resources. So let us know if you've heard of any of these resources before: Toolkit for Engaging Patients, Measure DX, or Calibrate DX. We'll leave that up for a little bit of time. Okay. I think any last takers? All right. Well, it looks like I'm really glad that I'm presenting on Calibrate DX because the majority of participants look like they know about Toolkit for Engaging Patients or heard of it. So about 76% of people who responded to this poll said that they'd heard of Toolkit, and 38% of Measure DX, and none who responded on Calibrate DX. So I'm extra glad that I'm going to talk about Calibrate DX today. Um, and then let's ask the next question. One more question, and it may overlap. So now we know who's heard of what tools. How many of you have used any of these resources in actual practice? So for example, if you've heard of Toolkit, have you tested it out in your practice? Have you used any of the components? I'll leave that up for a little bit. Okay, so I'm seeing that people really are using toolkit, that there are some folks who have actually used the toolkit for engaging patients. As we move into our discussion time later on, I will be really curious to hear your experiences using toolkit. I see maybe a couple for Measure DX. Really curious as to how that's going in your practice. Also curious if any of you who are using these two resources are actually in the Ideas project. And so that actually takes us to our next slide, which is who is participating in our project. So we are currently recruiting most actively for Calibrate DX, which is why I'm going to spend some time talking about that. But we've got right now over 150 sites enrolled and participating. They are primarily using Toolkit for Engaging Patients in their practice, as well as Measure DX. And you can see that they're kind of spread out. The circles are a little bit hard to see and to understand, but they essentially represent not single sites, but often they will represent larger healthcare systems that incorporate multiple sites. So the size of the circle, again, which is difficult to tell in the screen format, but the size of the circle relates to how many sites in that area. We are actively working with Convergence Health, one of our partners in more rural areas of the country, to engage hospitals and clinics who take care of patients in rural areas. We know that it is much harder for those organizations to participate in some of these QI initiatives, but we really do want to get rural representation. So we are continuing to recruit and include sites in our project, particularly for Calibrate. So I'm going to do a quick few slides on each of the first two tools. First being Toolkit for Engaging Patients to Improve Diagnostic Safety. This was actually developed in collaboration with patients as well as with clinicians, so it is very patient-focused. As I mentioned earlier, it is aimed at improving communication during the patient-clinician encounter and aimed at engaging patients directly in their care while helping clinicians to hear and reflect on their patient's story. Again, all with the purpose of reducing diagnostic harm. It has two pretty easy to use components. The patient component is the Be the Expert on You worksheet, which helps patients organize their thoughts and prepare for their conversation with their clinician. So all of us as people who have accessed healthcare in the past probably have had the experience of trying to figure out what are the most salient points that you want to convey to your clinician in the short time frame that we have to talk to our clinicians. So this patient-facing worksheet is aimed to help patients with that process. The clinician-facing component, 60 Seconds to Improve Diagnostic Safety, consists of a pretty brief training and a one-page planning worksheet that helps orient clinicians to offering a full minute of active listening without interruption at the start of patient visits. So the hope is that you can really marry a prepared patient who is communicating salient information to their clinician with a clinician who is prepared to sit and actively listen to what that patient is saying. So that is the toolkit. In our project, we are implementing this in any office-based practice. We need at least 2 to 3 clinicians to participate. We're finding that many of the sites, the ones that you see on the that you saw on the map earlier, many of them are actually implementing this across an entire clinic, across multiple clinicians, or even entire departments. And we are focused on primary care and specialty care because of the office-based component. MeasureDX is really designed for QI or patient safety teams. And as I mentioned, it is aimed at helping sites use data that you already collect to then identify diagnostic safety events and work as a team to discuss and identify what systems or processes could be improved along the pathway of identifying and addressing diagnostic safety events. This particular tool has a guidebook that helps QI teams walk through 4 specific steps. First is to prepare the organization for diagnostic safety measurement. So this includes figuring out what data you do have available at your site, who are the key leadership representatives that need to be engaged, what level of organization might you want to evaluate through the use of MeasureDX. The second step is a self-assessment, which is basically how ready are we for measurement. So some sites, I do the self-assessment and realize that they actually need to maybe modify the data that is being collected, maybe think about the timeline along which that data are collected and reported out, changing those existing processes to suit what they are trying to do with MeasureDX. So that's what the self-assessment really helps with. Once all those things are in place, sites then pick from and decide on a specific measurement strategy. So this tool actually identifies different types of measurement strategies that can be applied to identifying diagnostic safety events and helps QI teams decide what are they best positioned to select. And then they use that measurement strategy to then pull, review, and analyze cases of interest. In the process of analyzing those cases of interest, they are guided to discussing and thinking through how do we then, now that we're identifying diagnostic safety events, how do we then, what do we need to put in place to address those or improve diagnostic safety? In our project, we are including any healthcare setting in implementing MeasureDX. including those that are maybe newer to learning about diagnostic safety. So a question that we often have received is, well, I've never done anything related to diagnostic safety at the measurement level, or I haven't worked with my QI team before, but I have long wanted to try and figure out what data we do have at our site to improve diagnostic safety. MeasureDX is really set up to help sites take this on, no matter where they are in their diagnostic safety journey. We do ideally say that sites should have a QI team or a risk management team or a patient safety team that does have access to patient level data that can be used for measurement and tracking. For some sites, that's a that's a larger team. It might include a chief nursing officer, a chief medical officer, or a patient safety officer. It might include data analysts. So some sites have a lot more robust resources than others. In other sites, it might be one or two people who have sort of taken on QI initiatives in the past, have access to data, and have used that data in other initiatives to measure or look at different aspects of clinical care. And so it can really be any level of resources that a site might have access to. And we tell sites that are interested in using MeasureDX that you can focus on diagnostic practice, on a specific diagnostic practice across a single ambulatory clinic, a group of clinics. Most sites are looking at the hospital level and measuring events that occur at the hospital. Others are looking at specific units within the hospital if their data allows. So, for example, the emergency department or the ICU. Again, this is why some of the steps in MeasureDX are so important. You have to be able to kind of have data that parses out ED events from the overall hospital events. And some systems are set up to do that and some aren't. And so MeasureDX really helps establish a foundation of understanding around how do we use the data that are available to us to do what we want to do. So with that, I'm going to now turn to focusing on Calibrate DX. That is the focus of today's webinar. Just a note that if you're interested in learning more about the other two, the ARC website, we have a project page. There's a QR code at the end of this presentation that you'll see and a website URL. And on that website, there are informational webinars and other resources for each of the two diagnostic safety tools that I just talked about, Toolkit and MeasureDX. So I'll come back to that at the end of this presentation, but for now, let's move to Calibrate DX. So why might Calibrate DX be of relevance or importance to your efforts to improve diagnostic safety? We already know that delayed, missed, or wrong diagnoses are really common challenges for patients and families, as well as for clinicians. But clinicians rarely receive feedback on their diagnostic decision-making. There's opportunities that come up like M&Ms that there may be some discussion of what happened at the case level, but a specific clinician, with guided feedback and learning and close learning opportunity and reflection is rarely something that we offer to our clinicians. This lack of feedback leads to what in the literature is known as a calibration gap, which is the difference between what your perceived diagnostic performance is and what your actual diagnostic performance is. And so clinicians who are aligned on both their diagnostic accuracy, so they sort of close that gap, and in their confidence in diagnosing patients, we believe will achieve diagnostic excellence. So that's really the sort of theoretical underpinning for the development of Calibrate DX. Like the other two tools, this was developed at Baylor in partnership with MedStar, and it really focuses on helping clinicians use active reflection and peer feedback on their own cases to improve their diagnostic calibration as well as their diagnostic confidence. So it includes a self-evaluation tool that walks step by step, walks the clinician through selecting cases, reviewing those cases on a regular intervals, using specific tools like a fishbone diagram to reflect on their diagnostic performance, and then debriefing with trusted colleagues to deepen their learning about what they might do differently going forward. And one of the biggest value add that Calibrate offers is that it empowers clinicians. So really you're hearing the words empower, confidence, calibration. It empowers clinicians to learn from their own clinical practice through these structured exercises and tools. Like Measure DX, it includes 4 steps. The first is helping the clinician specify the area of practice that they're going to focus on. So depending on the clinician and the setting that they practice in, this might be higher risk situations. It might be diagnoses that are commonly missed or overlooked, or maybe diagnoses that we know are delayed in some way, that take a long stepwise process to getting to a final diagnosis. The second step is evaluation. So evaluating a small subset of their own cases within that area of practice for learning opportunities. And this evaluation step is really where the structured exercises and the tools come into play. And then the third step is planning and applying. So once they've taken their notes and they've sort of walked through these different structured exercises and tools and can identify opportunities for learning, or maybe for just walking through the diagnostic process a little differently next time, there's a step really focused on what kinds of improvement strategies might make the most sense for them to implement, and then to actually start to take action on those strategies. And if at these regular intervals, they are applying these improvement strategies over time in their case reflection, they should start to see differences in how they are applying their diagnostic process to this specific area of practice. And that's that final step of really reflecting on the calibration exercise over time. Between steps 2, 3, and 4, Calibrate DX includes um, instructions for debriefing your learnings as a clinician with somebody else that you're paired with. It might be a trusted colleague in your practice. It might be a clinical mentor, somebody who can actually listen to what you have reflected on in your evaluation of your diagnostic process and help you sort of deepen your learning and maybe even help you uncover things that you might have missed when you sat down in the first place. That's a big component of Calibrate DX. So as I mentioned at the outset, we're still recruiting for this tool. If there are sites that are interested in trying this out as part of this project, I'll talk about why it might be of interest to do it as part of this ARC-funded project. You can also do it on your own at a timeline that suits you. And this website I will take you to has all the resources. They're all publicly available resources. So you could always test it out on your own. But right now we are still recruiting for small or large group practices. It could be departments within clinics or hospitals, even possibly clinician training programs. We have worked with a few residency programs to set up a situation where they can test Calibrate DX. There are some challenges with that, which I'm happy to talk about if anyone's interested, that we are working around with a few sites. We really just need a handful of clinicians that would like to test this out, at least 4. That gives us about 2 pairs at a site who can work together to review cases. And we've got some sites who are testing Calibrate who are already in the field, who have just started. We're still in the training phase for sites who are interested in Calibrate DX, and we still have upcoming trainings. So why would you want to consider testing out Calibrate DX as part of this project? So of course, using Calibrate DX connects you to a group of other healthcare sites, and together you can learn and use innovative methods that ARC recently has developed for advancing diagnostic safety. More importantly, by participating in the project, you receive tailored support, technical assistance, learning collaboratives that are run by our partner IHI, as well as training on how to use Calibrate DX. So some sites are sending their, a site lead or a site champion to the training, and then that person goes back and sort of talks to clinicians at their site about how to use Calibrate DX. Others are sending their clinicians directly to our virtual training on how to use Calibrate DX. I mentioned the learning collaboratives, really peer learning groups facilitated by faculty at IHI, some of whom are participating in this conference today. We believe that using Calibrate DX and improving clinician diagnostic performance reduces opportunities for legal claims and lawsuits. We are offering continuing education credits, maintenance of certification for improvement activities, and a modest stipend. I already mentioned training. We've got Convergence Health providing technical assistance. That's one-on-one technical assistance for anybody who has questions or is having trouble implementing Calibrate DX or wants to know how best to onboard maybe a new clinic or a group of clinicians who are interested in using it. At the end of our project, we are planning on providing feedback to all participants on the impact of the intervention. So we are collecting some data on whether this is actually improving, for example, clinicians' confidence in diagnostic safety, whether it is having an impact on how they are thinking about their specific area of interest or area of practice. So we will be providing that back to all participants. If you're interested in participating, there are a few things to know. We are working on this. The RAN team, along with partners IHI and Convergence Health, are working on this for the next 2 years. That includes a year of providing implementation support to sites. So if you choose to try out Calibrate DX, there will be a year where we are actually providing you with the learning collaboratives, the technical assistance, and during which we will be asking clinicians to submit, for example, brief surveys about whether they feel more confident, whether they've got some self-efficacy in their diagnostic performance. At the end of that implementation period, we move into what we're calling a sustainment or sustainability period. And that's where we will work with each site to figure out, look, did it work for you to implement Calibrate DX? What was hard? What worked well? How might you consider continuing to use this in your practice? Or even better, how might you consider expanding this from the clinic that you tested Calibrate DX in and the 4 to 6 clinicians that used it to the next 3 clinics and the next 10 clinicians that might be interested in using it? And so IHI again and Convergence Health will be working with sites to figure out how to sustain use of these tools in practice. Obviously, there are things like making sure executive leadership is on board with testing out Calibrate DX, helping to identify the clinician participants who will be using this tool and engaging in, for example, the survey or an interview where we ask them how it went for them. Some sites have been, actually most sites have been identifying a champion or a lead that essentially helps to coordinate project activities and communicates with us. For Calibrate DX in particular, as well as, of course, for some of the other tools like Measure DX, you do need access to patient-level EHR data so that clinicians can then pull their own cases and review the diagnostic trajectory for each of their patients. And in some cases, you might need to help us identify site-specific contacts who can help troubleshoot any barriers that come up. They might be IRB barriers, privacy security barriers, IT challenges, confidentiality challenges. I will say that we have been recruiting since, it's probably since October of last year. So we've been recruiting for about a year for all 3 tools, which we have rolled out in a staggered fashion. And we started training sites that were enrolled in April. And we already have a number of sites using Toolkit and a number of sites using Measure DX, and Calibrate is just starting to come online. So we have a lot of experience now that we have accrued in how to sort of navigate any of the questions that healthcare sites might come up with. And it might not be you that come up with that question. It might be the person, at a different leadership level or at the actual clinic that you're engaging that will have questions. And we've been really, I would like to say, agile and flexible in how we respond to those. So here's where we see our Calibrate DX enrolled sites as of today. You can kind of see that they're spread over. We've got at least one circle, and I can't say with certainty how many sites that actually represents, but in this geographic region. So that's good to see. And we hope to continue to accrue more sites over the next couple of months for Calibrate DX. A few things here. So when this tool was pilot tested, when it was in its development phase, again with Baylor and AHRQ, pilot users were interviewed, and here are some of the reflections from the Calibrate DX pilot. One person said, I think it's helped me reason more and explain more of my reasoning in my documentation. I also think it's helped me naturally think about other factors at play in my own decision making. So this is really sort of reinforcing that it almost widens the lens, the diagnostic lens through which a clinician might be operating, and helps sort of it sort of serves as a nudge to clinicians to think about different aspects of the process. Another user said, hearing the reinforcement from my colleague and recognition of, and this was the quote, this sounds like it was a really challenging case. You did the best you could. Maybe here's one or two things I would have done differently that you could apply in the future. I think it was good camaraderie building and also reinforcement that we did the best we could. So I like this quote because it says a lot. It really reinforces the benefit of the peer debrief, working with somebody else. So you're not working in a vacuum as you think about your decision-making process. And again, there's this sort of widening of the lens, right? Here's one or two things that maybe I would have done. And there could be a conversation about that. Are those two things realistic? Are there things that I would think about in the future? And there's a little bit here that I really like of reinforcement that we did the best we could. Oftentimes these cases nag at you, right? And you think about it and it pops back into your head. And the next time you see a patient with similar symptoms, that prior case may come into your head. And so working through this and talking about it with a peer really can help bring about some sort of resolution almost that like, yes, I did walk through all of these steps. Here's some learning opportunities. Here's some things I might try out differently, but I really did walk through all the steps that I think we should have. And so I love this quote. I think it covers a lot of ground. And then, of course, my favorite quote in this entire project is, this is awesome. Like, I'm absolutely going to keep using this. That's the one thing that any, I think, health services researcher, if I put that hat on, wants to see, which is, I'm going to keep using this. And that's something that AHRQ has been very, very committed to. It is why when they developed this implementation project, they really thought about setting aside time to help practices implement and then help practices think about sustaining it. I think ARC is really, particularly in the area of patient safety and diagnostic safety, really focused on not just having researchers come in, have you do something, evaluate something, and then step back out, and then whatever happened in that research project goes away. Their goal is really much more practical, which is to get these tools out there, get them in your hands, have you use them, and then offer you some assistance on thinking about how do we continue to use these tools in practice. So with that, I'm gonna skip this slide. It's a little complicated. And I will put up this final slide. You see the QR code there. That will take you directly to the Ideas Project website, which is on the ARC site. So it is hosted by ARC. It is still up. The website still works right now. And you can see the URL there if you want to just sort of type in the URL if that's easier. Our names are up here as the co-leads of this project, Courtney and myself. You can always send an email to ideasproject@rand.org. Doesn't need to be, it's not case sensitive. So that's ideasproject@rand.org. And you can send any kind of email. So if you say, I listened to this presentation, I was vaguely interested, I'm not sure what the next step is, but I'd like to learn more, totally fine. I will get that, Courtney will get it. And I will mention that for each of these tools, the 3 tools I just mentioned, we have a dedicated team working with sites on just those tools. So if you want to, if you're interested in Calibrate, in addition to myself and Courtney, we have a team that is led by Dr. Carl Berdahl, an emergency medicine physician researcher, who will also be available to you to talk about what it might mean to implement Calibrate DX, either as part of the study or separately if you're interested in using Calibrate DX. So I think what I might do now, because I've been hearing my voice for too long, is to stop my share. May return to it if needed. And maybe we could go through, we could open up for Q&A and discussion. And Jonathan, I see things in the chat, so I can pull that up.
Yeah, I'm happy to read the questions if you like.
That would be great. Yep.
Yeah, so a few questions on Calibrate DX, and before we move on to the other topics. So, can you give an estimate of the time requirement per week or month required of participants, and on what basis
Yes.
would that vary?
Yeah, that's a great question. So we've gotten this question a lot, and I don't have it handy right now, Kate. I can find it and figure out how to get it to this group, but we have a table of rough estimates of time. The reason that it's challenging is because it really depends on how you at the site level decide to implement this. So there's a lot of flexibility. And you're right, it does vary by QI leader, clinician participant. So it does vary by who is doing what. So in brief, I can use, for example, Calibrate DX to start. So the clinicians, we estimate, quarterly reviews of their cases. So let's say they take 3 to 5 cases each quarter to review. Now, they can do more, they could do fewer. We think 3 to 5 is the right amount of time to really, apply the tool and learn. So, we think it takes anywhere from 2 to 4 hours for clinicians to review on a quarterly basis 3 to 5 cases. But that is going to be very clinician dependent. It's going to be very case dependent. The more complex the case is, the harder it is to collect data about the case. Like if they're trying to track down, whether referrals went through, whether labs came back in a certain time frame, that could take longer. But we think about 2 to 4 hours a quarter for clinicians to review 3 to 5 cases. On a quarterly basis, we also send surveys to those clinicians. They are anywhere from, for Calibrate DX, 3 to 7 questions, closed-ended questions. So our estimate for OMB purposes is that they take like a handful of minutes to complete. But, mentally, the mental labor of completing a survey, the invisible mental labor of like opening up the survey and like clicking through, um, make things also asynchronously. And then there's some offline training, which really is just going through what Calibrate DX is. It's sort of the bare minimum you need to do in order to be able to apply the tool. If you're a site, I'll just use that as another example. Like if you're a site that already has a robust measurement system and you already know, I'm going to have this patient safety person pull these reports down on a monthly basis so that we can track this kind of event, that's probably no time at all for some sites. Other sites where they think they have access to that, and this has happened, and they've realized that actually, in fact, it's a lot harder to get the data at the level that we want it. And it's going to require, working with an analyst that we may or may not have resources for, then it takes a little bit longer. I will note that Measure DX is a tool that is designed to be used as part of an existing process. So if a QI team already has regular meetings, that's where we think it's best used. Discuss the cases at those meetings. Don't add extra time outside of those meetings to do it. And for our data collection, surveys about how they've gone, how Measure DX is going, and event reporting, we highly recommend trying to sort of dovetail that with existing meetings. So I guess my long-winded answer is that it's really hard to estimate. I have a rough table that I'm happy to send to this entire group I apologize that I don't have it at my fingertips. I should have thought of that in advance. But the best way to get an estimate is for us to just talk through with you what it is you might be interested in or what your site might be poised to try out, and then we can give you a better estimate.
Right. I'm going to batch a couple of questions for the next question to you. So we know that in healthcare, a lot of the work, maybe most, is really done by patients and families, right? Getting to appointments, getting the medications right. And a lot of the work is done by clinicians behind the scenes, compounding medicines in the pharmacy, arguably the process of formulating a diagnosis. And a lot of work is done jointly between clinicians and patients and families.
Mhm. Mhm.
Uh, there's a discussion in the literature about how much of the diagnostic process can involve patients and families. So, uh, regarding Calibrate DX specifically, is there any point at which patients or families might be involved in the Calibrate DX process?
Yeah.
And if it emerges that there was a diagnostic failure, if that emerges from the Calibrate DX process, what are the thoughts on communicating that to the affected patient or family?
Yes, yeah, these are great questions. I'm so glad that you raised it. My research outside of this project in diagnostic safety is focused on the patient-family experience. So I'm really grateful for the participant who raised this and your encapsulation of this, Jonathan. Um, all that said, as part of our project, so as in Rand's role in this, we are not incorporating or eliciting rather patient and family feedback during our evaluation of the Calibrate DX, of use of Calibrate DX in practice. That said, some sites have decided to participate in this project, work, do what it is that we're sort of asking for, and then adding in layers of things that they think are important. So sort of using this project as a jumping off point for the things that they think really should be addressed. And what we're doing is kind of like the minimum necessary, like, let's get this resource into practice and see what happens. And some sites are actually expanding that to think more strategically about how patients and families fit into this. The related question you asked is also an important one, which is communication back to patients and families. So, and this is the reason why our involvement is what I would call, as somebody who does patient family focused research, what I would call very minimal, is we are trying to not create more problems for sites, to put it bluntly, or to put it crudely rather, than we need to. And so there is a component of concern around what happens if something is identified. We are very much letting organizations decide how they want to handle that, in part because it's really not, as an outside research organization, not our place to, to articulate that. And it is certainly not AHRQ's place as a funder of this work to articulate that. But it is an important part of closing that loop. And each healthcare organization has a different process for doing that. And we have worked in enrolling Calibrate sites and also in enrolling Measure DX sites. I will say this has come up. We have worked with the legal and compliance and risk management departments, depending on the site of some healthcare organizations, to figure out what kinds of data might come out of someone's use of Calibrate DX or Measure DX, and how does the organization need to be poised to respond. So again, I apologize. That was a long-winded answer. The short answer is we do not have plans as part of this project to elicit patient and family feedback, which is disappointing. And we are encouraging sites to think about how they might do that and other things, using our project as a jumping off point.
Great. A more technical question. So we recognize that Calibrate DX is primarily for the benefit of the clinicians, right, to get feedback on the quality of their work. But is there a way that this can be, that the learnings can be aggregated somehow for the purposes of organizational learning? Are there reports available where to track gaps between the documented diagnosis and the Calibrate data?
Yeah, that's also a really good question. So To us, that is a site level question. It is really up to what data the site has available, and I see some questions related to this, what, HIT capabilities they have to be able to pull data like this. We have had a couple sites ask us these sorts of questions that I think go like 3 steps beyond what we're trying to do, which is great, which is really thinking critically about how do we take Calibrate DX and get more useful information to the organization, not just the individual clinician. Now, Calibrate as a tool is very focused on improving diagnostic performance at the individual clinician level. But it is a great point to raise that you can actually aggregate probably some of this to then think about, reporting around on an organizational level. Where's this calibration gap? What does that look like? We are absolutely, like, we've got experts between the physician researchers on the RAND side and all of IHI faculty that are working on this, many of whom actually worked to develop the tools initially in the prior phase. We have lots of experts who are available to talk to sites who may have ideas like this about taking this tool and taking it farther.
And
Yeah.
Calibrate DX enrollment is still open, right?
Yes, Calibrate DX enrollment is still open. So we would love for people with these. I mean, I'm seeing great suggestions and actually great questions that are really suggestions in the chat. So especially from this group, we would love to see participation.
Shifting briefly to the Engaging Patients toolkit. So does the toolkit have any recommendations or guidance for how to incorporate this into the electronic health record?
Yeah, that's a great question. So the tool itself, and I see the other related question, the tools they are packets of information. They're guidebooks, and they are easy to use, easy to read, easy to follow. It's not like an IKEA instruction manual. It is very much like, this is what the tool is aimed to do. Here's your step one. Here are the structured exercises that go along with step one. Here's the appendix with the fishbone diagram or the deer taxonomy that relate back to, the Calibrate DX calibration exercise. So they're not health information tools. They're not IT tools. They're not EMR based tools. That said, we've had sites be the expert on you worksheet and toolkit and stick it into their patient portal so that when a patient has a visit, a primary care visit, in addition to the confirmation of this is when your visit is, please fill out this paperwork before you come. The Be the Expert on You worksheet is in there. And there's a little sentence that says, please review this, before you come to the clinic, or bring it, and there will be a copy at the clinic waiting for you to help you think through, so however they've decided to word it. And we've worked with some sites to figure out the specific wording. It's, again, very site dependent. If you have the patient portal capabilities to do that, and you've got an IT team that is willing to put this in right away, or you have access to being able to do this yourself, it's very doable. We've converted the actual worksheet into different formats so that it can be more easily integrated into a portal or an EMR. So these are all options. And again, things that we're happy to work with you on.
Great. Returning to Calibrate DX, can you say just a little bit about how the cases are selected?
Yes. They are self-identified by clinicians. So we do very little to constrain participants in how they use this tool. But per Calibrate DX, per the tool itself, there is explicit guidance on how a clinician might think about the kinds of cases that they want to evaluate. And the guidance is around things like, there should be a thread that hangs these cases together, because it's very hard to learn from very disparate types of cases where the root cause might be significantly different. It talks about how to consider what is a high risk area that you may want to focus on. It guides clinicians in thinking about what are challenging cases to diagnose. So if it's, something that typically has a sort of wayward path or is a little bit more indolent or involves connections with lots of other specialists or with labs or imaging. Um, those may be things on the one hand that you do want to focus on. On the other hand, may be harder to get all the data you need to have a useful reflection exercise. And so there's all this guidance in the booklet related or in the guidebook for Calibrate DX. So they are self-identified by clinicians, but there is a fair amount of guidance given to sort of scaffold their thinking in how they identify it.
Mhm. So turning to think about how, if anybody participating in this session wants to go back to their organization and try to generate interest in participating in Calibrate DX, some practical thoughts. So what specialties would you say have been most receptive to participating, or maybe a related question, in which specialties do we think we'd get the most bang for our buck in calibrating diagnosis?
Yeah, that's a great question. I mean, I might actually take that second question and throw it back to the group as a group that is much more knowledgeable about where they perceive the bang for our buck in this space. I think that Calibrate is aimed at, and we're seeing this in who is responding to us on this, um, really in two places. We're seeing EDs interested in thinking through this. Um, we're seeing outpatient primary care clinics and specialty clinics. Our specialty clinics, I'm trying to think about, I feel like we had, like, for example, a pulmonology clinic, um, uh, just enroll. Radiology was another one that we've had a few radiology practices reach out to us about using this. Oh, I see this in the chat, emergency rooms radiology. Um, and primary care, and different kinds of primary care, adult and pediatric primary care. So I think those are probably, it's the environment in which a clinician has diagnostic scope of practice, has control over that, has it within their scope of work, and can pull a case and sort of walk through all the pieces that happened. Um, those are the environments that we're seeing it mostly.
And then anticipating a question that's sure to come up some places, doesn't medical staff peer review already perform this function? Isn't
Yeah.
this redundant?
Yes. Okay. Great question. I really appreciate that question. We like to think of it, and I think this is, I believe this, that the tool itself is much deeper and more detailed in helping a clinician think through this than most peer review environments. It is also a lot less, I don't want to say punitive, but a lot less, it can be done in a less high pressure, stressful sort of context, because it is so focused, even in its language, so focused on the individual clinician's learning and, again, widening that lens, the aperture through which they are seeing their own diagnostic performance. That said, we think that the tool is very easily integrated with some of these other existing processes like peer review, the M&M, and a way to sort of do this in a less resource intensive way or minimally resource intensive way, is to take the tool and bring it to those sessions, right? Or sort of like incorporate, and however they run, incorporate the use of the tool into the practice of peer review so that you're sort of, I wouldn't say redundant, but like killing two birds, which is always such a horrible thing to say, but like killing two birds with one stone. And so it really then gets at improving the peer review process, right? Like making the peer review process a little bit more robust, a little bit more about learning and growth. So it's actually a really efficient way, I think, to implement this tool.
Mm. Well, if there's any other questions, please put them in the chat, or any that I missed, please bring them to my attention. For those who a concern that, well, this is more work, I'm reminded of the quote that's attributed to the gentleman who gave us lean methodology. It's attributed to him that, we all have two jobs, doing our work and improving our work.
I just responded to something in the chat, but I wanted to go back up to, I think I saw a few questions around disclosure and um, ethics. So, and I spoke briefly about the disclosure back to the patient. Um, we, I just want to note that our legal and compliance, as well as our IRB, have spoken to any sites that have asked us about what do we need to do if something happens, if we identify something as a function of this project. Um, as a non-healthcare system ourselves, we, are not our rules are a little different, and so we're not able to sort of say what a healthcare system should be doing, or what they are legally required to do. But we have been in communication with legal departments and again, like risk compliance, and are happy to continue to do that. And as I mentioned, the IHI faculty who are on this project, who are on the development of Calibrate DX, have a lot of experience working with compliance and risk management departments and figuring out how to use Calibrate DX. For the most part, the tool itself is not focused on uncovering diagnostic error as much as it is focused on learning and sort of helping clinicians close their calibration gap, agnostic to how you would define an actual diagnostic error. And so, in the use of the tool, I think we'll sort of find out, like, to what extent do these other issues arise.
Mm. So to continue with that for just a moment, because we're nearly out of time, but Yanling asks a follow-up question about the individual actions, and it's really self-reflection to a large extent, isn't it?
It's self-reflection, but it might be that that as a result of their self-reflection, a clinician identifies, for example, next time someone comes in with, I'm just going to make this up, these three symptoms that I was unsure of this time, I'm actually going to do this sooner. Like, I'm going to take this action sooner. I'm going to order the lab sooner, or I'm going to, put in a consult sooner than I did in these. And then I'm going to see what happens, like whether that changes the course. That's really what it means by individual level actions. It's really in their own diagnostic process, what they think they might want to do differently.
Got it. Well, that brings us to the end of our time this morning. Sangeeta, thank you so much for this great presentation and for all the great work that you and your colleagues are doing to try to improve diagnosis.
Of course, it's everyone here who's doing that hard work. So my thanks go to all of you, and thank you for giving me the opportunity to present this. Remember, if you have any questions or interest, ideasproject@rand.org. We're always available. I'm on the other end of that email, so I will be able to reach back out directly to you.
Well, thanks everybody for attending this session, and don't go too far. The next session starts at 10:30 Pacific time. We'll see you then.
Thanks,
Thanks
everyone.
again.